start off, I do want to say thank you guys to those of you that have sent me videos so far for the International Day. I've gotten quite a good number so far. So thank you very much. I think it's going to be really good when I splice those together. And on that subject, I'm going to go ahead and extend the deadline on that. If you still would like to send a video, I encourage you to do so. I've gotten a lot of entries so far, but it's not taking me as long to splice them together as I thought it was going to. So if you still would like to send something, please, by all means, do that. I've gotten some really good ones so far. You guys are being very creative. So really looking forward to seeing the final product. But yes, if you'd still like to send an International Day video, you have a few more days to do that. So send it over to me, and we will add it to the overall spliced video. So go crazy. Send me whatever you come up with. Looking forward to what else you guys are going to send over. All right, let's go ahead and jump into our next chapter for patient care. I believe if I'm looking at the syllabus correctly, we have just 3 chapters left overall for this semester. So we're about to wrap this thing up. We're already almost halfway through November. It's going to wrap up really quick. We're getting towards the end here. On that subject, just a reminder, guys, make sure if you have not got that first competency yet, make sure you get that done. You do remember to pass the semester, you do need to have one competency done, at least one competency done. You got a lot to choose from at this point. You're about to wrap up lower extremities. You've already done uppers. You got chest, abdomen, a lot of stuff to choose from. Do not wait to the last minute or you're going to start panicking. You're going to get nervous and you can't control what comes in. You need to try to do that now. If you have not done so already in clinic this week, get that competency done. And just a reminder for those of you that are coming this week for your practicums, if you have image reviews that need to be done, please bring your numbers with you and we'll take care of those at the conclusion of the practicum and make sure you're caught up and ready to go. Yeah, it just needs to be, from what I understand, just one competency. You just need to have one competency done by the end of this. I don't think necessarily has to be chest. I'll make sure that's correct. But from what I know, it's just supposed to be one. Of course, if you can get more than one, please do that. A few of you have already come to me and you have a good handful already, which I'm very happy to see. If you can always stay ahead of those requirements, by the time you get to that last semester, it's going to be a lot less headache. In fact, just before class, I had a senior just text me that she just completed the last of all her competencies today. So she gets to go to her last semester with nothing to worry about. She's got to go to clinic and do her time, basically, and she can focus on studying for the registry. That's the best thing you can do for yourself. So get out there and go crazy, guys. Get as many as you can. It really does pay off by the time you get to that last semester. You know who it is? Who do you think it is, Tracy? How'd you know that?
Easy. She's number 1 in the class. Smartest one. And she tutors everyone. So I would know.
Well, good guess. Good guess. You are accurate. All right, let us jump into, you knew it was Amna because you met her once. All right, let's jump into the next chapter, guys. We're going to learn a little bit about pharmacology, drug administration, needles, drug rights. Very simple concepts, but also very important concepts because, man, one thing I know, when it comes to patient care, the registry loves to ask about drug administration questions. We're going to go over what the main ones we need to know about are. Now, when you say the word pharmacology, if you're like me, you flip out because, man, oh, man, let me tell you, when I was in school, my worst subject of all the subjects in my radiology program was pharmacology. Now, when I was in my school program, thankfully, you guys don't actually have to take a pharmacology class, but in my x-ray program, they made us do a full-fledged pharmacology class, which was actually a nursing class. And the reason for that was, at my school in Lake Charles, the nursing program and the x-ray program were under the same overall jurisdiction, basically. They were in the same area. So we had to take a pharmacology nursing class as part of our required classes, and it was an absolute nightmare for me because pharmacology is a lot of chemistry. Now, if every one of us have what we call our Achilles heel when it comes to school courses, my Achilles heel to this day is chemistry. Pharmacology is very chemistry based. I can look at chemistry every day for the rest of my life, and I'm just not going to compute it. Now, I can quote you the periodic table of elements. That's no problem. When it comes to doing these chemical equations and all that wonderful stuff, it just does not compute in my poor head. So if you have any kind of chemistry-based questions, I recommend you go see somebody else. Any other subject? Hey, I can help you out. Come to me with those questions. But chemistry, yeah, it's not happening. It's not happening. But luckily for you, the pharmacology that we have actually go over that's radiology based and what you need to actually know for your registry is a very, very small portion. And you're going to see that in just a second as we move forward here. A very, very tiny amount you need to know for chapter 21 here. So pharmacology, here we go. We got to define what a drug is first of all. A drug is, by definition, any chemical substance that produces a biologic response in a living system. That is the word-for-word definition of a drug, very important one to know. Now, a drug can be used as medicine to aid in diagnosis, treatment, or prevention of disease. And when we actually talk about the science, that scientific study that's concerned specifically with the origin, nature, and effects and uses of drugs, that's what we call pharmacology. Know the difference between the definition of a drug and the definition of pharmacology itself. So basically pharmacology, the science, the study, how we learn about the drugs. And the drug itself is that actual chemical substance producing a certain biological response in a living system. And obviously that is extremely broad, extremely broad. Good thing to know is, like I said before, you don't have to learn all those millions and millions of drugs. You go into nursing, you do have to know all those drugs. I mean, it's like it's a Bible thick of drugs you gotta learn. But in radiology, what are we most concerned with? Well, that's gonna be our contrast mediums. And we're gonna hit those specifically as we move on. But luckily, our list is so much smaller. It's still a lot, but it's so much smaller compared to what nursing has to learn, thankfully. Thankfully, I'm thankful for that. For pharmacy techs, you know the top 200. Yeah, I forgot about pharmacy techs. Yeah, what Esbede's holding up right there. It's quite a nightmare. It's a lot to memorize. If you've looked at drugs, you know they're not all just the general names like Tylenol and ibuprofen, Advil. You got to know the chemical names as well, which are quite extensive on some of them. It's quite scary. But we're going to learn a few of those as far as radiology is concerned, especially with the injected contrast mediums that we'll talk about as we move forward here. Now, you're going to see a lot of times when it comes to drugs, a term called nomenclature, drug nomenclature. That is, by definition, what we call a classified system of names in regards to drugs, in regards to naming our drugs. That classified system of names goes by the word of nomenclature. And there's three major classifications that we are concerned about. That's going to be the name. Now, when you say name, that does include all three of those things you see right there. That's the chemical name, the generic name, and the brand name. And we're going to learn those when we talk about the radiology drugs that we get to moving forward here. The second classification would be the action, what actually happens when you take that drug. And then the classification under classification. Classification has a classification called classification. Not confusing at all, right? That third one is called classification, and that's referring to the prescription or the non-prescription of that drug. So name, action, classification are the three classifications of our drugs. All three of those fall under what we call nomenclature. Nomenclature, that's the classified system of names in regards to drugs. All right, so a lot of physicians, well, in fact, all physicians should have this book on hand. This is what we call the Physician's Desk Reference, also simplified to what we call the PDR. Very important book that physicians must have. It's going to list all those drugs under all those classifications that we just talked about. That's the main point of having that Physician's Desk Reference. If you ever want to see one, it's a mass of names, drug names, categories, effects, scientific names, chemical names, compositions, Everything you ever want to know about a drug is found in that book right there, and physicians are required to have that on hand because if you remember, we as techs are not going to be assigning drugs to our patients. That's done by the actual physician, and they use that, what we call the PDR, to reference those drugs. If they have any questions, if they don't know what they're ordering, if they don't know what the effects are, they can always go to that PDR for reference. Physician's desk reference. By the way, I don't have any Seinfeld fans out there. That's what you're seeing on these GIFs. Older sitcom from the 90s, something I used to watch all the time. I've got all the DVDs. It's like my favorite sitcom back in the day. If you won't know what show that's from, it's from Seinfeld. Okay, so we have what's called the drug profile. This can be found in that PDR. These are very important to know. You want to write these down and know what they're referring to. We actually profile a drug. It's based on all these bullet points you see right there. So the chemical composition, how is that drug chemically formed? What are the chemical compounds that go into that drug? The absorption characteristics, a lot of these are actually within the name, by the way. How is that drug absorbed by our bodies? What actually absorbs the drug? What affects it? The distribution characteristics, how that drug's actually distributed through our bloodstream to the organs, to the areas of the body that drug's actually going to affect. Metabolic characteristics, how it actually metabolizes within the body. Elimination, how does our body get rid of the drug? Most of the time, from the blood to the kidneys, and we urinate or defecate that drug out. But each drug is eliminated a specific way. Most common would be through the renal system. Indications, action, and effects. What's it actually going to do to us? The interactions and the contraindications, and then the patient reactions. A lot of these seem to overlap a little bit, and that's because they do, especially the last three. There is a little bit of overlap there. That is the main that's the main areas of the drug profile, and every drug that we use in healthcare is going to have each and every one of those bullet points represented specifically. And that's what we call a drug profile. So how would the registry ask you a question on that? They may list a bunch of those in front of you. They would say, which of the following are considered part of a drug profile? They would have, for example, chemical composition, absorption characteristics, distribution characteristics, metabolic. They might throw a few randoms in there, and you have to pick out of that list. They might have 8 of them listed. You would say maybe it's A, B, C, D. You might say A, B, E, F, something like that. But you'd have to actually pick those out. You know, identify those are part of the drug profile, but make sure you can pick out the ones that would not fit in there. That's the most likely way the registry would actually ask you a question on that. They're not going to get super detailed on this pharmacology, but they would definitely ask you a question on that and make sure that you know what fits within the drug profile category. Now, you remember I said pharmacology is going to be short? That's all we're learning about pharmacology, just those few slides. Now, we could spend an entire class going into extreme detail of it. As far as what you need to know at this present time in regards to X-ray radiology, that's all you need to know so far. Now, if you go into another modality, and we're talking about CT and MRI, you're going to get a little bit more in depth on pharmacology because there's a lot more contrast mediums and drugs that we administer in CT and MRI. That's going to come later to you as you further your education. That's the main points of pharmacology I need you to know right now for radiology. We're still going to name some of these specific drugs, but we're going to dedicate an entire chapter to that specifically as well. So now we're going to talk a little bit about the principles of drug administration. How do we actually administer these drugs? We're going to learn a little bit about venipuncture, something you guys are going to be doing in your practicum, something that some of you have already done as well. We're going to talk about the needles. We're going to talk about how they actually insert them, the different methods, so on and so forth. The actual drug rights as well. We're going to hit the drug rights first of all, which is very important to make sure we all memorize. And that's the 5 rights you see before you right there. The 5 main patient rights when it comes to drugs. We must always administer the right drug, the right amount, the right patient, the right time, and the right route. 5 simple concepts, but easy to forget. That is a big star slide right there. That is something you do not want to forget from now until you take your registry. You will get a question on that. Because we are administering contrast mediums, we must know specifically those 5 rights that patients have when it comes to administering drugs in the radiologic field. Right drug, amount, patient, time, and route. Sorry, I missed your question. I didn't see it pop up there. Can you either type that back in or ask me your question? I didn't see that in time. We'll put that in.
Mr. Donahue, for as far as the reading for chapter 21, we still read the whole chapter?
You can if you want to supplement your knowledge, but for chapter 21, all that you need to know as far as registry is concerned is the stuff I put there on the slides for you. Because it can be a complete mess trying to read that pharmacology. It's great to supplement your knowledge. By all means, read it if you're interested. But the main things you need to know for your registry on pharmacology, chapter 21, is what I put in there. Chapter 22, yes, read it all. Read it all as we move forward here. Good question, by the way. Sorry I didn't specify that. Now let's talk about the right patient. Obviously, this not only applies to drugs, but it should apply to what you guys are doing in clinic right now when you get your patients. I sure do hope all of you, as you go out there and get a patient, that you are asking their name, you're checking their armband, you're asking for that date of birth. Is everyone doing that? I hope everyone raises their hand, please, please, please. Because one of the biggest mistakes people make, whether it's drug administration or x-rays, is they get in a hurry, they're not paying attention, they'll call a name, 3 people will stand up, they'll take a person, and they got the wrong patient. Has anyone encountered when they go out there and call a patient's name that 3 people stand up or like 3 people raise their hands? Has anyone had that happen yet? Yeah, a few of you. You got to make sure you're checking those armbands, making sure they're repeating that information back to you. And that's very important with drugs. The last thing we want to do, of course, is do the wrong exam on the wrong patient. But we really don't want to be administering drugs to the wrong patient as well. All kinds of lawsuits can come out the wazoo on that, as you can imagine. So, of course, guys, it's back to day 1 of patient care. What do? Read that patient's identification number and medical number. Make sure it's matching what's on the order. Check that patient's birth date. Have them repeat that back to you. Make sure it's printed on the armbands. If that patient cannot speak for themselves, if they're too young or they actually cannot speak, you want to make sure you confirm that with a family member, someone with them. Don't just assume you have that right person. Let me ask you another question. Has anyone encountered yet going to get a patient that they don't even have an armband on? Has that happened to you yet? Same person raising their hand? You're just having all the bad luck as Betty. But yeah, that's something you're going to encounter, guys. And let me ask.
It's outpatient clinics, so they don't have the same name, first and last name the same. It's just the second last name was different.
Yeah, it's aggravating. That's where I say those dadgum nurses. Come on, I apologize if you have a nurse family member or love a nurse, but I always say those dadgum nurses. They forget those armbands all the time. So I saw Jonathan raise his hand. Jonathan, what did you do when you encountered that patient without an armband? What was your reaction to that?
So there was one time it actually happened in the hospital where the patient came in and didn't have an armband. And I didn't really know this is like my first week, I think, there. So I just kind of stayed back and let them handle it. But they went through some protocol and ended up finding out exactly who it was and getting an armband, or they got something. I think it was an armband made for them. But they went through several different checks to make sure that it was them. But and then another thing, like I noticed, in the outpatient clinics especially, is the language barrier. So if you're trying to identify with them, sometimes they don't really understand what you're asking. So some of the techs will be just to try and get an ID from them if they're by themselves.
And that's a great point to bring up, Jonathan. And I'm glad you brought that up because I know these are simple concepts here, guys, but this is so important because last thing you want to do is end up with the wrong person because that can cost you your job. Yes, that can cost you your job very quickly. There are a lot of language barriers, especially here in Houston. We're an extremely multicultural city. Do not ever for 1 second assume that you have the right person, especially if they can't communicate with you. You want to make sure that you go get someone to translate for you. Every hospital has translation services. Yeah, you might be in a hurry. You might be behind on your x-rays. but it pays to be thorough and to not risk doing that wrong patient, because I've seen it happen, guys. I've seen it happen so many more times than I wish I could say I have seen it, where people are in a hurry and they do the wrong patient. Someone says, yeah, I'm John Smith, but they don't even know what they're saying. They're just raising their hand. They get the patient. They don't look at the armband, and they just did the wrong patient. John Smith was in another department somewhere. That happens all the time. Be thorough. If they can't speak English, get translation. If they're missing an armband, do not ever do that exam. I don't care if you tell them their name and birthday and they repeat it back to you. Do not ever do a patient that's missing an armband. That can cause all kinds of lawsuits, medical malpractice, wrong patients, all the above. You always are going to send that patient back or call the nurse and have them bring an armband over to you before you proceed with that exam. You might get some pushback. You might have the nurse say, "Oh, it's fine. That's the right person. You go ahead and do it." No, you always get an armband. Period. That's a big, big deal. And I've seen it happen, guys. I've seen people lose jobs over that. Don't put yourself in that situation. Even if you see techs do that, that's the wrong mode of action. Don't ever put yourself in that situation. So this is just reiterating what we just said, guys. Obviously, if those identifiers do not match, like if you have the order for the medicine, if you have the order for the x-ray, if it does not match your information, you're going to stop immediately, get that corrected before you move on. Then you're going to proceed with the exam once everything is checked out. Now, of course, also, much like we do with x-ray, you're always going to explain to your patient why you're administering the drug, how it will be administered, and why it's being done, what it can do, what the effects are. There's some other questions that we'll learn that we ask as well, such as allergies, shellfish allergies, reactions, so on and so forth. But you're always going to explain how that's being administered when you administer that drug, why it's being used. We're giving you contrast today, sir, ma'am, so we can light up your organs. Oh, you're here for a swallow study. We're going to have you drink this barium so we can see the inside of your throat, using those layman's terms. Oh, okay, you're here for CT. We're going to administer some contrast into your veins. We're going to inject it into your veins using this power pump here. You're going to explain exactly what's going on. Don't assume they know what's going on. You might feel some heat on your body. You might get some metal taste in your mouth. That's totally normal. We're giving you this contrast so we can see your insides more clearly. This contrast, don't ever use the word dye, by the way. This contrast is going to light up your organs. Does anybody know why you wouldn't want to use the word dye? A lot of techs make that mistake. Why would you not want to say the word dye?
They think you're like staining their organs or something.
Maybe, but that's a good point to make, by the way. But some dyes, guys, are poisonous. There's some dyes out there that are poisonous. You don't want to make that kind of confusion for your patient. Don't ever use the word dye. A lot of old school technologists will say, "We're giving you some dye right now." Don't say that. Don't say that. It can cause unnecessary panic. It's always contrast medium. And if they want to know what contrast is, it's a liquid to help light up your organs so you can see it on the x-ray. Light up your body parts. Use those layman terms. So the right time, very important point. We always want to make sure we're giving those drugs at the correct specified time. Now, this is not your responsibility. You'll see there in yellow right there. Who's the one that's responsible for the time? That's always, key point, always the physician or the practitioner responsible for ordering that specific drug. So yes, you're going to go get the contrast if you're doing a study on a patient, but that's not you deciding when that contrast is administered, even though technically you are giving it at a specified time. The doctor is ordering when that drug is administered. That is their responsibility. So your responsibility is to administer it at the time specified by that doctor. His bone clinic part. I'm not sure what y'all talking about in the chat there. I missed something there. So, of course, like we talked about last chapter, guys, as a technologist, you should be aware of all the different signs that can happen. When you administer that drug, you need to know what the mild signs are, the moderate signs, and those severe allergic reactions. Because you might talk to a patient, you're doing your interview with them, "Hey, have you ever had an allergic reaction?" They'll say no. All of a sudden, they break out in severe hives. You're not just going to ignore that away, like, "Oh, well, they said they didn't have allergies. That must be normal." No, that's something you got to be able to react to quickly. If they start going to anaphylactic shock, you got to jump in there quickly, know how to react, just like we talked about in the last chapter. So you got to be familiar with those different signs that can happen. And of course, different drugs, as we'll learn, have different types of reactions that are normal versus mild, moderate, and severe. And we'll be able to identify those as we move forward. Also, big key point. I didn't put this in bold, but that is very important to make sure you write that down. Anytime you administer a drug, you never, ever, ever want to leave a patient unattended. I don't care if they're drinking contrast medium, if they're drinking barium, or if you're actually injecting something through the rectum, through the urinary system, through their veins. You never leave a patient unattended when a drug is administered, because a reaction does not always happen immediately. It can happen at any point, at any time. You could turn your back for a few seconds and they're going into shock. You could walk away to go get an x-ray cassette. They're going into shock. You would always want to make sure someone is there watching that patient, whether it's a family member, a nurse that's with them, another tech. You would always want to say, hey, let's say that Jolie was administering contrast and she needs to go get some more x-ray cassettes. She's using an old CR system. She's got to go get some cassettes, or she's got to get more contrast. Jolie would say, hey, Maricela, will you watch my patient really quick while I go get some more supplies? You're never just going to assume they're fine and walk away. It's a big no-no. Big deal with drugs, because you never know what kind of reactions can manifest, and it can happen in a matter of seconds, very quickly. Something very serious, something to always keep your eyes on. Always have eyes on that patient. As it really should be anytime, guys. I mean, I'm going to go on a limb and say even when you're just doing regular x-rays, you always want to make sure someone's nearby. Let's keep an eye on patients, especially if they're on a table, because what's going to happen when you walk away, they're going to roll off that table and blame it on you, and you get in trouble. You always want to make sure there's a pair of eyes watching that patient as much as possible. I know sometimes that's impossible because we don't have the staff, but try your best to always have someone there with you, keeping eyes on the patients. You'll learn to read patients pretty well as you get more experience. You'll know which ones really need like 4 pairs of eyes versus one that you keep out the corner of your eye. You'll learn that really quickly, especially if you go into pediatrics. The right route. So obviously, guys, we got to make sure we put that drug in the right area. If they're calling for a barium swallow study and they want the patient to swallow the barium to visualize the esophagus, I do not want to administer that through the rectum. I do not want to administer that through the veins. I need to make sure I know what I'm doing, why I'm doing it, and I'm using the correct routes. And that obviously applies at veins too. There are certain veins you don't want to inject certain kinds of contrast into because the veins may not be able to handle it. There's different things that they call viscosity. Viscosity is the thickness of an actual contrast medium. I don't want to put certain viscous contrast mediums into certain veins because I might blow the vein up. I'm going to cause injury to the patient. I need to know what the specific route is. I need to make sure I talk to my physician and know what route he's administering. On that point, some physicians like doing things differently. Some doctor over here might like to administer it one way. The doctor over here might want to use a different route. There's multiple routes for administering drugs. You need to make sure you specify that from the physician, document it. And by the way, that's one of the questions you're going to get on your orders. When you close out an actual order from an x-ray that's involving contrast medium, it always asks you what was the route. What was the time, by the way, when we went over time? It asks you a lot of these questions we're talking about, and you need to make sure you're writing these things down. You never want to just assume, well, I gave it around 12 o'clock. I don't know for sure. You need to know for sure when you gave that contrast medium. Why? If something happens later, they need to be able to trace that back and figure out why it happened, when it happens, to document on that patient's history. If you injected that contrast medium into the antecubital area of the arm, you need to document, I put it in the antecubital area, or I use the brachial area, the brachial vein. I need to make sure I specify where I'm putting that contrast. If something happens, they need to trace that back and know what's going on. If I injected that contrast into the brachial vein and they start getting a bunch of swelling and infection on the antecubital, well, guess who has egg on their face? Me as a tech. Because I documented it was in the brachial, it actually manifested in the antecubital, and I'm in trouble because I didn't specify exactly where that route was. Know where you're administering the contrast. Know where you're putting that drug in that patient's body. That's a liability issue that can come back on you if you're not very specific with it. And of course, you as a rad tech are going to be familiar with the terminology. We're going to go over some of that terminology as we move forward through some of these slides. Going ahead here with those common routes. We'll learn what they are, what they look like, where they're actually located on the arm, mouth, etc. They all have different terminologies associated. So these rights we talked about, guys, it's not only to protect the patient, but it's to protect you. So you always want to be very specific when I say I'm going to make you sick of this statement, guys. When I say document everything, I'm telling you, you're going to be sick of me saying it. But it's so important, guys. So important you write this stuff down and you're very specific. Don't ever assume anything. Make sure you write everything down, put it in accordingly on those patient charts. It is going to come back and bite you in the rear end if you don't, if something happens. Okay, so very important points here, guys. When you administer drugs, this is going to exactly what I was just talking about. It goes with the rights we just talked about. You got to write all this down. You don't just say, well, my brain's going to remember. I'm just going to assume when I put the orders into Epic, it's going to be fine. You need to write this stuff down and be very specific. You'll see techs that are good at their job. When they do a contrast study, there's going to be numbers all over that order sheet. There's going to be times. You want to write all this down so you don't make a mistake when putting this in the patient's charts. Don't assume anything. Always record the name of the drug. You need to be specific. What am I using? Am I using barium sulfate? Am I using Optiray? Am I using Isoview, Omnipaque? There's a bunch of different drugs. Be specific what that drug is that's being used, because that needs to go in the patient's charts. You need to put the route of administration, like we just talked about. Where did they administer the drug? Was it swallowed? Was it injected? Did it go through the rectum, through the catheter of the urinary system? Whatever. The time, boy, that's important. Make sure you write the time of administration. As soon as they drink that first cup of barium, you need to write down, this was done at 9:10 a.m. Began ingestion of barium at 9:10 a.m. If I'm doing a barium enema study, barium was administered rectally at 10 o'clock a.m. Put the times down specifically. Record the patient's reaction. If you see them just have a normal reaction, if they get flushed, if they have heat, if they taste metal in their mouth, yes, those are expected reactions, but you still want to record it, that it happens. If they get hives, write it down. Be specific. Hives manifested on my patient at 10:30 a.m. Simple as that. Write it down, put it in the patient's charts. Yeah, it's going to feel like it's too much. You're going to feel like Kramer here on the side. That's how it feels, but you got to do it, guys. It protects you, keeps you away from any kind of legal issues that might arise, because in the day and age we live in, guys, I don't have to say, people are going to sue at the drop of a hat. If something weird happens, they're going to sue it, because you can sue legally for anything these days. They might say that you looked at them funny and they want to sue the hospital. Sounds funny, but people will try to do that. So when I say, you're going to be sick of me saying, document everything. Please document everything to cover yourself. You can't take anything for granted. Now, drug errors. So this is a big point here. This is a registry question. That big yellow statement there at the top of the screen. You want to write that down, put a big star on it. Errors associated with drug administration are among the most common legal problems in which radiographers are involved. And why is that? Because they're not doing this stuff right here, guys. Let me go back a slide. Those four things right there, the techs get lazy when they get in a hurry, when they just don't want to be bothered with it. It leads to that major error right there. That is the most common legal problem in the radiologic field. Lazy techs, not documenting, not doing things they should be, doing the wrong patient, doing the wrong area, doing the wrong exam, etc. That is the most common legal issue that we as techs face. So you gotta cover your tracks. Make a paper trail. Now, how do you save yourself? Let's say Tracy up there, she's been told to use some Optiray on her patient for a cystogram. Well, she just, she's not paying attention. She thinks that doctor is a weirdo. I'm just going to go get some barium sulfate and inject that through the bladder into the kidneys. Well, first off, that's a bad idea. You're going to cause a major rupture in that patient's urethra and bladder. But she makes a huge error. She uses the wrong drug. So Tracy says, well, you know what? They survived. It was weird. The doctor didn't see it. It's okay. I'm not going to say anything.
They survived.
Either way, patient has a major reaction a few days later. They investigate this, and they find out Tracy used barium instead of Optiray. So Tracy didn't report this. So guess who's about to lose their job? Tracy's about to lose her job, and being that this is a small radiographic community, she can't get a job anywhere else because word spread in the community that she used the wrong contrast on a cystogram. Sounds silly, but that actually happens, guys. Word travels in this community very quickly, and things stay on your record. It's hard to get a job if you get fired in X-ray. I'm just going to put it plain.
Mr. Donahue, I have a question.
Yeah.
I know whenever you get hired, like you get malpractice insurance and stuff like that, and even for students, I know we kind of have it, but wouldn't you get sued as well? Like, I know like they can sue the hospital, but wouldn't they sue you as a person as well?
They can, yes, and that goes to how well did you cover your tracks. So if you're doing what you're supposed to be doing, that leads me to this next point. We are human beings. We make mistakes. If you've never made a mistake in your life, guess what? You're going to make a big mistake in your life. If you think you're always going to do the best x-rays, you're going to be the best tech that God ever created, I hate to burst your bubble, but you're going to make a mistake. You're going to do the wrong x-ray. You might use a wrong drug. You might make a major mistake. How do you protect yourself? You do what's in that second bullet point right there. You always immediately report it. That is the best way to protect yourself from any kind of issues where you might lose your job. If you try to cover it up, if you try to hide it, and you get caught, then you might want to go back to school and find out a career because you're not going to get a job anywhere else. So yes, there's different things that protect you legally, but what can protect you in your career as far as keeping your job safe and advancing yourself in the career is when you make a mistake, guys, and you will make a mistake, you immediately report that to a supervisor and I would say and physician. Be honest about it, guys. People know that we're human. They might fuss at you. They might get upset. But you are better off protecting yourself in that fashion than trying to cover it up and act like nothing happens. And there are a lot of unethical techs out there, guys, that think they're smarter than the system. And they might get away with it for a little while, but they always get caught. There was a tech that I worked with at Texas Children's. I'm not going to name names, but they thought they were going to be really slick. And they these two techs started taking x-rays of each other. They started taking x-rays of each other's feet because someone was complaining of foot pain. They covered it up. They hid it. They said, oh, we'll delete the images. No one will ever find out. Well, what have I always said, guys? In this day and age we live in, you can't hide stuff. Everything's traceable. Someone ratted them out. Another tech that I worked with, it wasn't me. I didn't rat them out. Someone ratted them out, and they traced it back, and they found the deleted images. And they immediately both were terminated, lost their jobs, and they never got a career in X-ray again because they thought they were going to cover that up, thought no one would find out. What they should have done was, they did something unethical, but had they owned up to it and not tried to cover it up, they would have secured their job. They would have gotten in trouble, written up, yes, but they would have secured their job. I can tell you guys, that's a fact in any place you work with. If you just own up to a mistake, you're going to protect yourself for anything further down the line. Don't ever hide stuff or cover it up. It's all traceable. They will find out. I don't care how slick you think you are. They will find out. So medical abbreviations, most drugs that we use have multiple abbreviations. So we need to make sure, though, when it comes to the drugs we use in radiology, we need to know the full names and the abbreviated names. I'll show you which ones specifically as we get to those. Now, those actual abbreviations are going to be published by the Joint Commission and Institute for Safe Medication Practices. They're going to actually list what's considered an acceptable abbreviation versus an unacceptable abbreviation. And why is that important? It goes back to documentation again, guys. If you abbreviate a drug, please know what you're abbreviating. Otherwise, just write the drug name out. If you don't know that actual abbreviation, don't make one up. That can cause major mistakes down the line. That can come back and be a liability issue on you if you accidentally abbreviated OptiView versus Omnipaque, and they assumed you used OptiRay when you should have used Omnipaque, and that's a lawsuit against the hospital, and you're in trouble because you used the wrong abbreviation. So on that subject, my personal recommendation, guys, when it comes to documenting drugs, just write the whole word out. You're less likely to make a mistake if you just use the whole word instead of just using abbreviations. Not that it's wrong to use abbreviations, but you're better off keeping yourself safe if you just write that entire word out. It'll give you a lot less errors. I've seen some weird abbreviations out there, cause a lot of confusion. So one thing you'll learn, there's so much involved with X-ray. People get that tunnel vision, like all I do is position my patient and push a button and send them on their way. There's so much more to it, guys, when it comes to ending your orders, documenting your orders properly, adding that information. It can be work. It can be a whole job in itself, just ending patient orders. I don't know if you've watched any of your technologists. Someone probably fly through it quick. Those doing what they should be doing are going to be adding all kinds of notes, making sure they're specific with everything and doing it correctly. It's time consuming. It is time consuming, but it's necessary. So very necessary. All right, when it comes to units of measurement, we use the metric system for drug administration, and we're always going to base those units on units of 10. And the three main measurements that we're going to use with drug administration are going to be meter, liter, and gram. That's for measuring mass, volume, and length. Meter, liter, and gram. So the three units of measurement that we will use for drug administration in the field of radiology. Those are all based on units of 10. Once again, simple concepts, but so important, guys. So important to remember these through registry. Okay, so when we talk about the actual actions that drugs take, how the body reacts to them, they're based on these bullet points right here. You need to know that these are factors influencing drug actions, very important ones, simple but important. Patient's age, obviously as we age, we have different reactions to different drugs. Their health status, big one right there. The time of day, people forget that based on the time of day, there are different reactions drugs can actually cause. Their emotional state, that's one people forget as well. A person's actual emotional state can cause different reactions to drugs, especially for psychotic drugs, antipsychotic drugs, other drugs in the body. We should know not all drugs are compatible. There's certain drugs you never want to take with another drug. It can cause a very dangerous reaction to the body. Genetic variations, different variations within our genetics can cause different reactions, and of course the disease state of the body. Different infections, different types of disease in the body, different pathologies can cause those drugs to react differently as well. So 7 very important points there, simple but important to know that those are factors influencing drug actions. Another way, registry could do a listing question on you right there. Okay, so we're going to talk a little bit about our drug administration routes now. These are some more very important points, guys. You need to write these down, put stars on them. Simple concepts again. I know for a fact that these are registry-based questions right here they can ask you. So we have what's called enteral versus parenteral routes. So for our enteral routes, that's going to be oral and rectal. Oral and rectal. You want to write those down, put a big star by that word, enteral routes, oral and rectal. Oral breaks down to two different categories. We have what's called sublingual and buccal, or buccal, or said both ways, buccal or buccal. When we talk about a sublingual route, that means going under the patient's tongue. The drug is under the tongue. Buccal or buccal is under in the patient's lower lip. Like you see this picture right here. That's the lower teeth, and that's the lower lip. And of course, rectal through the rectum. Oral, of course, refers to through the mouth. Our two enteral routes are oral, rectal. Oral breaks into two subcategories, sublingual versus buccal. Buccal or buccal. And of course, when we talk about enteral routes here, what would we use in radiology that's enteral? Well, any of our contrast that's being drunk orally would be enteral. Any contrast that's going through the rectum and a barium enema would also be enteral. There's 2 very good examples there. Drinking contrast or administering contrast rectally. Anyone ever get a suppository when they were kids? I think those things are of the devil. I hate those things. You don't have to answer that question. That's just a hypothetical question. I am very anti-suppository. Now here's a few more here. We have what's called a topical drug administration. Topical can be a drug that's just administered on the surface of the skin. So like a skin cream, like Neosporin, things like that. Anything that you're rubbing on the surface of the skin, actually rubbing it on the skin, is topical. Now that has a subcategory that we call transdermal. Transdermal means a medication that's administered on a bandage on the surface of the skin. You see in the picture right here. So a good way to remember that, topical, you put the drug on top of the skin, topical on top of the skin. Easy way to remember that. And of course, we have one of the most common ones that we know about, guys. It's called parenteral. Parenteral refers to any kind of actual needle injection through the skin. There's multiple ways we do that. You'll see the subcategories right there: intramuscular, intravenous, and subcutaneous. There is also one called intraarterial. You don't see listed there. You can write that down if you wish to. But the three main ones that we're going to deal with in radiology are intramuscular, intravenous, and subcutaneous. At least the ones we're talking about in this chapter. There's a few more than that, but that's the main ones we're talking about in this chapter. Intramuscular, by the way, refers to a direct injection into the muscle. Direct injection into the muscle. Intravenous is putting contrast or medication through a vein. Subcutaneous refers to administering a drug or medicine through the layers in between the skin and the muscle. It's the area between the skin and the muscle. And then intraarterial, the other one I talked about, would be into an artery. All of those are what we call parenteral routes of drug administration. That's what you guys will be doing in your venipuncture practicum with me this week. Parenteral administration, parenteral routes. And that's just showing you a little bit more about what we just talked about, guys. We have, and this is another subcategory as well, intradermal. We don't do this in radiology. This would be an example of what you get done for your TB tests. Oh, you had a TB test where they put the little medicine right under the skin. That's what we call intradermal. The three main ones to remember for radiology are that intramuscular, which is straight into the muscle, subcutaneous, between the skin and the muscle, intravenous, into a vein. And you do want to know these angulations here, guys, because depending on the way we administer the contrast or medication, we have to use a different angulation on that needle. If we're injecting directly into the muscle, we're going to use a direct perpendicular 90-degree injection angle. And there's someone in this class that tried to do that in lab. During their practicum last week. I'll let them speak up if they wish to, but that was the incorrect way to do it. She's raising her hand. There you go, guys. So Jessley did a intramuscular injection on her venipuncture last week, which was incorrect, but she fixed it very quickly and did it correctly. You know?
And I got a good flow. Don't forget that.
Say what?
And I got a good flow. Don't forget that part.
You got a good flow when you did the intravenous method. Yes. Subcutaneous, that's the area between the muscle and the skin in the middle. That's going to be a 45-degree injection angle. And the one you guys need to remember the most, because this is the one you're going to do for your practicum, is that intravenous angle, which should be approximately a 25-degree angle when you're entering into the skin, into that vein. And the reason for that is, for those veins that we're injecting into, guys, you have to enter in a 25-degree angle, because essentially when you're injecting a needle into a vein, you're threading the vein. If I used one of these other angles that are sharper, like the 90 and 45, what am I going to do? I'm going to go straight through the vein. I'm not going to hit it at all. I want that needle to be inside the vein. So I'm threading the needle into the vein with that 25-degree angle. It's very important to remember that. Probably the one you get asked the most, guys, would be this one right here, intravenous 25-degree angle. That's what you all have to perform for me. That's also what the registry, that's the method they would love to ask you about right there. Intravenous routes. Using that 25-degree angulation to enter into that vein. Now, as far as our drug administration supplies, we're going to use a syringe and needle, of course, for parenteral administration. Why? Because we're injecting into the skin, most often into a vein or artery. And the angiocath, this is what you guys will use with me for your practicums. The angiocath is the safest and most effective device when performing venipunctures in radiology. In radiology, by the way. Not so much other areas, but in radiology, the angiocath is the most effective and safest piece of equipment that we're going to use. And then you're going to hear about gauges of needles. That's talking about the actual diameter of the needle, how large that needle is. One thing to remember when it comes to needles, the larger the number, the smaller the diameter. The smaller the number, the larger the diameter. It's inverse. It's an inverse relationship. When we talk about our syringe, it is made of 3 specific parts. We have the plunger, the barrel, and the tip. The tip is where the needle is inserted into. The barrel is what actually holds the medication, and the plunger is what actually administers the contrast. And we go back to tip, that can be where the needle's inserted or where we actually insert the syringe, where we put our injection. Like if we put an angiocath into a patient's arm with a needle, I'm going to put the tip of this syringe on the end of that angiocath to administer the contrast. Just that connection point between the angiocath and the actual syringe. Some syringes will have the needle on them already as well, depending on what you're actually using. And this is the last slide we'll do today, guys. This is talking about those needle gauges once again. Make sure you remember this is another big gold star question, guys, that I know Registry likes to ask. They're going to ask you about gauge sizes of needles. Make sure you know that the larger the number, the smaller the diameter. The smaller the number, the larger the diameter. You can see those pictures right there. The big needles, the ones that feel like it's like someone's putting a bullet in your arm, are going to be those small numbers. Versus the little tiny ones like the butterfly needles are going to be on the higher end of that spectrum with the numbers. Make sure you know it's an inverse relationship. Inverse relationship. And that is a good stopping point for today, guys. We will stop there and we will finish up this chapter on Wednesday. And then your exam on this will be next week because International Day is on Friday. We don't have class on Friday. At least not my classes. Okay, any questions on what we talked about today, guys? All right, well, as always,